Hello and welcome to our show. We are very fortunate. I'm Dr. Barken and I'm going to interview Dr. Katharina Pachmann, whom I had the pleasure also to talk with her son Peter Pachmann on the issue of circulating tumor cells and the whole area of trying to find diagnostic by using personalized deduction from what we find in the blood, either in circulating tumor cells or otherwise. So, Professor Pachmann, welcome to our show.
Thank you very much. So, I would like to elucidate a little bit about the Mindtrack method in contrast to the cell search method. The cell search, as you already pointed out, if you find two cells, that's prognostic. We think it's different. We don't do any enrichment, no fixation, so the cells which we find are vital cells, and there are many more than what you find with the cell search method. And if we find cells, this does not tell you that there are metastases. Such cells can circulate in the blood for years, and they are somehow dormant, as you already are aware of. But
so forgive me, so you mean that the circulating tumor cell may come from the primary tumor, so that's one of the issues, whether what we see in the blood is coming from the primary tumor, from the lymph node, from the other metastatic location. I guess that's what you meant.
Yes.
Okay.
Well, from the beginning, we don't know what they are coming from, but what they tell us is if they start increasing in numbers during the course of disease, that's a sign of tumor activity. So, for example, if we can monitor the number of cells during a therapy, and we see in most cases a nice decrease of the circulating cells during therapy if the cells respond to therapy. Then we can monitor them after therapy, and if we then see a re-increase in cell numbers, this is a sign that there is again tumor activity.
Okay.
So we think our method is mainly made for monitoring therapy, and then after therapy, if there is a renewed activity of the tumor.
So you're an advantage because the cell search, they found very small amount of circulating tumor cells, while you find a lot of cells, and there is change in the number that's easier to see. So basically, it's not specific to find what kind of treatment. It's more prognostic to tell us whether it's the activity of the tumor or not.
Yeah. Well, whether the treatment works, then you see a decrease in cell numbers, and if you see a re-increase, this is a sign of renewed tumor activity. But what we can do in addition with these cells, since they are vital cells, we can expose them to the drugs planned for therapy, and we can see whether these drugs kill the cells directly. So we do not rely on an expression profile of the cells, but rather on their killing directly by the drug.
I see. And that's done in a test tube, sort of speaking, not in any kind of a culture or other tissue. Because one of my questions I had, since tumors are, let's say, in the bone, could we do testing when the tumor is kind of almost as close to the in vivo, create a culture of bone together with the cells? You are doing it for the time being. You are doing it just in a test tube without any other organic material.
Yes, and we do it in a short time incubation, and we can only test drugs which have cell killing activity. So, for example, what we can't do is test hormone blocking therapy directly on the cell. But monitoring hormone blocking therapy is possible, and we can nicely monitor, for example, during androgen receptor blocking, that the cells remain stable or even decrease in numbers, and this is correlated to outcome.
Very good. So that makes it very clear. That's why I had in mind about the difference between chemotherapy or cytotoxic drugs versus hormonal deprivation, which is harder to prove in the test tube. But you would look at the number going up or going down, how they respond to treatment. Okay?
Yes, that's exactly. So, and we, as you see on the next slide here, we use the EPCAM. That's what the cell search also uses, but we don't use them to isolate the cells. It's just to find the cells.
Okay.
And you can see in the next. So that's what these cells used to look like. And for the chemosensitivity, no, I don't have it in here. But the next question which you asked is what's the difference between circulating DNA and circulating tumor cells? Yeah. First of all, you told me that cell search only finds 2 cells. We find many more cells. So the sensitivity is very much comparable to the circulating DNA. I would even claim that we are more sensitive than the circulating DNA, because the circulating DNA is coming from killed cells, from cells which have have been killed.
Yeah.
What we are looking at is vital cells. And then, as I told you, if we see an increase, that's a sign of tumor activity. Whereas if you see an increase in circulating DNA, this would be a sign that there are cells, more cells killed. And it's known that during therapy there is a spike in circulating DNA.
Okay.
The advantage of the circulating DNA is that you can look for mutations.
Right.
We can also look for mutations in the circulating cells. We can isolate them individually and look for mutations, but that's quite a cumbersome work. And maybe circulating DNA is easier to work with in this respect.
I see.
But on the other hand, it's known that you find a lot of mutations in the circulating DNA, some of which may be induced by degradation of the DNA. And it's, as I mentioned, it's coming from dying cells.
Yeah.
So if we are analyzing the DNA from our individually picked cells, it's DNA from live cells. And we can look for known mutations like KRAS mutations, BRAF mutations, and comparable mutations. We are just going to publish this. That's not published yet.
Yeah, it goes without saying that please, I would like to follow you. If you would have a Twitter account, I'll get on your Twitter account, but I would like to always be informed on any paper that you write so I could follow up about the advancement.
I will provide you with any paper we have published. We recently published a paper in eCancer, and there's something more we can do with the circulating tumor cells. We can induce a small population of these cells to form tumor spheres.
Interesting.
And that small population is the population which is capable to clonally expand and grow. And we think that's a prerequisite for metastasis formation. And indeed, we can see a tight correlation between the amount of tumor spheres we can induce in the patient's, from the patient's blood, circulating tumor cells, and the stage of the tumor.
So just the ability, so let me just understand it, so just the ability to create those spheres gives you information about capability or potential ability to metastasize.
Yes, we think so. And we are just going to publish a paper on the properties of these spheres, and they have typical, we have shown this at the ASCO last year, they have typical expression profiles of tumor stem cells. The sphere cells in the spheres have typical patterns of tumor stem cells.
That's a new area for me, and I do not know if you could sidetrack a bit and just explain what is a tumor stem cell, because the purpose of this presentation is actually for patients, and they hear a new term, tumor stem cells. We know about stem cells, but tumor stem cell may be new for them. Could you just explain in a short manner what is tumor stem cell?
Yes. It's assumed that not all tumor cells are capable of forming metastasis, or that's sure, but it's a small subpopulation of cells which can self-renew, which can replicate all the time, and these cells are called tumor stem cells, and a typical ability of these cells is to form these tumor spheres, which are sort of a clone of cells which forms a round sphere. And so we can track these cells, which are assumed to be the tumor initiating cells and also the metastasis initiating.
So when you say stem cell, we know the stem cell could turn into any type of cell in the body. So are we talking here about different type of mutation from the stem cell?
No, it's not yet known what enables the cell to be a stem cell. It's even not known whether this is a stable stage of the cell, or whether some cells can move forth and back to be stem cells and to be dormant cells, for example. And whether
so we still do not know. Yes, so forgive me. So we still do not know those stem cells may affect the local growth of the tumor locally in the area, or whether it will be the source of metastatic disease. It also has activity with the local tumor, because I find very interestingly different clinical presentation of people that don't have any metastasis at all, but they keep growing locally and cause a lot of local control problem. Some of them go to lymph nodes and never cause any problem at all to the patient, but the most dreadful one is the metastatic to the bone, disease to the bone. So we know from stem cells that probably if they are able to create spheres, they will create metastatic disease. But we do not know what kind of metastatic disease they will develop. Am I correct?
You are correct, but perhaps when we are able now to more go into the expression profiles of these cells in the spheres, we might become able to tell even to what organ they preferentially might migrate.
You have a genome profile of the stem cell.
We have an expression profile of the, yeah. And we are doing this just now. We are doing a lot of profiling of these tumor spheres to see what profiles they have. What we can already tell is that they have a lot of expression of so-called stem cell genes. Genes which tell they are able to self-renew and probably also to metastasize.
Very good. Thank you for making this point very clear.
Okay, so I hope I made the point clear also between the circulating DNA and the tumor cells, and I think they will, in the end, they will be complementary.
Good, very good.
Any more questions?
Yes. I think that it will be a nice place, natural, to wrap up our conversation here. A very practical question. Could you let me know, how do I tell the patient what is the perhaps mechanism to send you samples?
Okay.
And how, if you don't want to get into cost, that's fine, but I want to be practical, because once the patient watches it and he wants to take action, yes, he could call me and ask me, but maybe you could give your phone number or maybe your website or a bit of information. What's the mechanism? How do you send the samples?
Yeah, we have a website, and it's www.maintrack.com.
Okay.
There's a lot of information on this website, and you can download lab request, and the sending of the sample, it's just EDTA blood, uncoagulated blood, which you usually draw into blood count tubes. What we need, or what we would like to have, 15 ml, that's sufficient to do also chemosensitivity on these cells. And you can send it by FedEx or DHL. They know how to transport, and it's just normal ambient temperature. And
very good.
Usually it arrives at our lab between 48 and 72 hours later, and that's enough for us to count the cells, and even if requested, to do chemosensitivity on them. No cooling, just ambient temperature.
Very good. I really appreciate all the information in this interview. I really enjoyed talking to you, and I want you to continue. You mentioned chemosensitivity. Perhaps another time we'll talk a bit in more detail, because that's a very hot topic for patients about this chemosensitivity, and perhaps we'll talk about it more another time.
Thank you.
So thank you very much for being on our show, and I appreciate all your help.
Thank you very much. Thank you very much, Dr. Barken, for inviting us to present our results here.
Okay.
Thank you.